So end-of-life care is the last year of someone's life. Now obviously this is difficult to predict, but there are certain markers that we can use, and it tends to be when people are deteriorating in their health, becoming generally frail because they're old, or they have a terminal illness and that's starting to progress towards its terminal stages. So within the last year of someone's life, so that is the definition of end-of-life care, we know that averagely patients will make approximately 14 consultations with their GP. We also know that currently the average person within the last year of their life may also attend hospital 3 times in that last year and be admitted. So it's important that they're engaging with their healthcare professional, and we try and make a good plan for them. Also, in terms of achieving a good death, we want patients to be prepared and planned for getting what they want, and particularly important, what their family and their carers want. So this involves just thinking about what would happen when it comes to those final few months, few weeks and few days. Who do they want around them? Where do they want to be? What do they want to happen? And importantly, what do they not want to happen? Is there any specific treatments that they do want to happen and they don't want to happen? And of course, there's always the issue around whether they would actually wish to have any attempt at resuscitation at the time, when the time comes that their heart stops and they stop breathing. That's the discussion about the do not attempt cardiopulmonary resuscitation, or the DNA CPR. So this is the point where someone is in the final last few hours of life, and then their heart stops and their breathing stops, so they have passed away. Having a DNA CPR then in place, be that in the house or in the care home or in the hospital, means that any healthcare professional who's on the scene at the time or who is called to the scene doesn't have to attempt resuscitation on that patient. And for most people, they'll have seen resuscitation on the TV on programmes like Casualty and ER, and that involves attempting to get someone's heart restarted by chest compressions and attempting to get them breathing again through artificial means. There's always a very small chance of this actually being successful. However, if it is, there's a very high chance that patients will end up needing transfer to hospital and being on a life support machine. This then may delay their actual death, and then puts the family and the carers in the situation that they then have to have a discussion with the hospital about when potentially to withdraw life support. I think as a culture in England, we're quite bad at talking about death and dying, but when it comes to individuals, when you're speaking to them on an individual basis, and that could be any healthcare professional, be that a GP or a practice nurse, or a clinical nurse specialist, say from a palliative care team, that when people are actually nearing the end of their life, they want to start thinking and talking about these things, and often they're worried about discussing it with their family, and they're worried about discussing it with their carers and their friends, and that actually they do appreciate someone bringing up those conversations and starting them off and starting them on the right thoughts. As a patient, if someone does feel they're nearing the end of their life, or they've been given a terminal diagnosis, then they can discuss it with any healthcare professional. Obviously most people would tend to come and see their GP, and it's something they could say that they were worried about the future, they thought about planning the future, those sorts of things. As a CCG, we have introduced an advanced care plan, which is a document where people can record their wishes about the future, and it includes those conversations such as where they would like to be cared for, where they would like to pass away, what treatments they would like, what treatments they wouldn't like, and who's to be their advocate or spokesperson for them when they're not able to do those things. So our vision is that patients are supported throughout that whole last year of their life, that they're recognised as being in that situation, and they're supported by giving them information, and that's from a multidisciplinary team. So it will obviously involve the GP, but potentially also a practice nurse or a hospital clinical nurse specialist if they, for example, had a cancer, as well as the palliative care clinical nurse specialists, and then of course there's our district nurse team who actually go into people's homes and may be involved in them throughout their last life in terms of symptom control, bowel care, potentially wound care, wound dressings and other things along those lines. Most of them, like I sort of said earlier, are actually quite pleased that you've broached the subject with them. I think it's something that's very difficult to talk about. No one wants to admit that they might be coming towards the end of their life and that they might be not around for their friends and their family. But in the same way that people would make plans in terms of their money and would write a will, this is basically a healthcare version of that, but it's not legally binding, and it's more a document for them to record their thoughts and their wishes at a time when they feel able to make them, and not waiting till that crisis happens or until they're too weak to do so.